Hello, I'm Dr. David Quek. I'm a cardiologist at the Pantai Hospital in Kuala Lumpur, Malaysia. And welcome to this presentation titled, Why is it important to screen Asian patients and to reduce LDL cholesterol? Now, hypercholesterolemia is the critical risk factor associated with rising burden of cardiovascular disease globally. Now, in the prospective studies collaboration, we know that ischemic heart disease mortality is related to the level of cholesterol that you have. The higher your cholesterol level, at whatever age group, you are more prone to having more ischemic heart disease mortality. When you're younger, say the age of 40 to 49, the risk is very steep. At the same time, if you are able to reduce the level of cholesterol by even 1 millimole, at the youngest age group, you're going to achieve the best results, sometimes by as much as 56% of the risk. The Asian Pacific cohort studies zoom in on our population here in this region, where it showed essentially the same phenomenon. We are not different from Western cohorts. When you have hypertension, when you have associated high cholesterol levels, you will have higher risk for coronary heart disease as well as stroke. And this is seen across the board. It's especially important in the younger age group where if you are less than 70 years old, the curves for coronary heart disease, for ischemic stroke, for hemorrhagic stroke is very steep compared to those who are above 70. There's no difference between being a man or a woman. Now, having said that, how well Asians are not spared from atherosclerotic cardiovascular disease, and elevated plasma cholesterol levels are an important risk. Now, the WHO has actually got this global database which suggests that for Asians in particular, the disability-adjusted life years lost due to cardiovascular disease in the Asia-Pacific region as of 2005 may be more than 50% of the global numbers. And this is an important phenomenon for us to address. More than half of the world's CVD disability are in the Asia-Pacific region. The InterHeart study, which actually looked at the levels of LDL versus the ApoB as well as the ApoA1, demonstrate a very close linear relationship across the board from various areas, from northern, eastern regions, in South Indians, South Asians, and even from Hong Kong, China, as well as in Southeast Asia and Japan. So the InterHeart study showed that if you have an elevated LDL cholesterol or a high ratio of the ApoB to ApoA1 ratio, which are the atherogenic particles involved, then you have the highest risk for the first acute myocardial infarction. And this is further elaborated upon when we look at how much we should be lowering our LDL in patients in Asia Pacific. If we look at the various strategies that has been proposed, we need to be able to risk stratify and evaluate our patients better and see what are the best levels of LDL cholesterol to target to for the most optimum clinical outcomes. Now we've got the very good, robust European guidelines. We've got the European Association for Diabetes. We've got the American guidelines. Overall, they tend towards some of these numbers. But it's important to note that based on usually the starting LDL cholesterol level, we need to set some goals for the reduction. If not in absolute numbers, at least by some set percentage. I think here we are most agreed that we need to reduce by at least 50% of the LDL cholesterol from the baseline. Now, the American Expert Consensus Guidelines in 2016 has used these patient risk groups based on their assessment of atherosclerotic cardiovascular disease risk assessment above 7.5%, above 10%. One of the criticisms about these guidelines is that although it uses a baseline LDL level, it has not proposed a target or goal-driven kind of a therapy. And this has actually caused a little bit of confusion among Asians. Most Asians actually prefer the use of the ESC, EAS guidelines of 2016, where the various risk categories are very well defined. And I think here, in a very high CV risk patients, we will use a goal of LDL-C of below 1.8. This gives a lot of confidence for the patients and the physicians to target to. At the same time, for those with lesser risk, just with high CV risk, then the target can be a bit less at 2.6 or below. Now, we also know that just using statins alone, we may be able to achieve some control of the LDL cholesterol, but it is not always that we can do so. We know from our experience that various statins have various potencies, the most powerful of which are atorvastatin and rosuvastatin. And one of the reasons why the statins are considered the base backbone therapy for reducing LDL cholesterol is that the Cochrane review, for example, found that this is actually the largest meta-analysis that we have on now currently 25 major studies. And the benefits of statins are very clear across the board. They've all-cause mortality reduction, cardiovascular disease events reduction, fatal, non-fatal coronary events reduction, stroke reduction. The American Association of Clinical Endocrinology in 2017 has proposed another risk category, the extreme risk. Here we have the progressive atherosclerotic cardiovascular disease patients who develop unstable syndromes, even in patients who have achieved an LDL receptor of less than 70. We have those with established clinical cardiovascular disease patients with diabetes, chronic kidney disease and failure, and heterozygous familial hypercholesterolemia, and also in those with a history of premature ASCVD. Here, the proposed LDL cholesterol is for reduction is to less than 55 or less than 1.4 millimole per liter. The association that of achieved LDL cholesterol and major coronary events has been very well described. And this is particularly important in the secondary prevention trials. And I think the final conclusion of this analysis by Silverman is that in most of these meta-regression analyses, the use of statin and in non-statin therapies act essentially by upregulating the LDL receptor expression in order to reduce the LDL cholesterol, in other words, to remove the LDL from the circulation. And this is associated with very similar risk reductions of the major vascular events per change of LDL cholesterol level. So it's important to consider not just statins, but also perhaps some other agents. For example, in the recent Improve It study, a reduction of LDL cholesterol from 70 to 54 is associated with better primary endpoints, better cardiovascular disease events, as well as the primary and three pre-specified secondary endpoints. This gives a lot of credence to the fact that whether you use a statin or you use another additional agent to help reduce the LDL cholesterol further, it is useful. This is further sustained when we have this study by using a PCSK9 using in the Fourier study. This is further confirmed when the Fourier study, it was just released this year, showed that the LDL cholesterol that can be lowered to as low as 30 milligrams per deciliter or about 0.8 millimoles per liter is associated with better cardiovascular outcomes. There's much widening of the curves, as you can see, both for the primary efficacy endpoint as well as for key secondary efficacy endpoints. And this tells you that it's very safe as well as very effective. So how are Asians doing with regards to the LDL-C reduction and therapies? Are we managing our patients well enough? Well, we have some Asian data. But the Reality Asia data here, a study showed that when most physicians do not change or up-titrate the dose of statin prescribed after the first visit. You can see that across the board from my own country, even in Malaysia, as many as 85% of patients were put on their first dose and the dose carries on forever. High cardiovascular risk patients who achieve LDL-C of less than 100 range from as low as 16% to 56%, and most, only about 1 in 3, achieve the target goal. So overall, the LDL cholesterol control for all categories is actually less than half. And this is not a very good way of managing our patients. Now, if you look across the board, we know that 52% of Asian patients at high cardiovascular risk did not achieve their consensus cholesterol treatment targets, particularly for those with higher cardiovascular risk and also for those whom we want to target the LDL-C goals lower. More than 40% of patients who failed to achieve the target of the LDL-C of less than 100 usually have the starting dose which is not increased. And most patients, even if they were up-titrated, as many as 50%, did not achieve the LDL-C target that was agreed upon. So this data indicate a need for a more effective treatments to help more Asian patients achieve their guideline-recommended cholesterol treatment. And in fact, when we look at the more recent study called the CAFIAS Pan-Asian Survey, we again showed that overall the use of therapies to lower the LDL cholesterol, we have not been very successful. For example, only about half achieve certain number of LDL goals that we have set. And for very high risk categories, only as much as about 1 in 3 get their levels under control. And this is on top of the varying regional and country differences. Hong Kong doing better, but across the board, you'll find that most of the Asian countries do not achieve nearly as good target as we would like them to be. And this is on top of the use of widespread use of statin and also on use of additional therapies. For example, the other therapies, you'll find that only about 50% are able to achieve these targets. So in conclusion, Asians are facing an epidemic increase in the incidence and prevalence of atherosclerotic cardiovascular disease, with higher stroke, myocardial infarction rates. Half the global burden of disease is now occurring in the Asia-Pacific region. Lifestyle changes, increasing sedentary lifestyles, occupation, adoption of Western food habits, different adaptation towards these metabolic syndromes might play important roles. The Asian risk profiles are not significantly different from the Western cohorts. The high LDL cholesterol levels, high lipoprotein A, low HDL cholesterol, widespread hypertension, higher incidences of dysglycemic syndromes, diabetes, are important determinants that are still poorly recognized, managed, and treated. And younger patients are increasingly succumbing to premature episodes of fatal and non-fatal acute coronary syndromes and strokes. So the treatment to target goals for LDL cholesterol are still very suboptimal. So appropriate and aggressive statin doses with or without other LDL lowering agents such as ezetimibe or the newer PCSK9 inhibitors are needed to achieve this better, especially if the target LDL cholesterol cannot be achieved or when there are intolerable adverse side effects. Very low LDL cholesterol, even as low as 30 milligrams per deciliter or 0.8 millimoles per liter, appears to be safe, but this needs to be assessed on a cost-benefit evaluation. Better commitment to guideline-determined management of atherosclerotic cardiovascular disease is critical to stem the epidemic of premature deaths and disability in Asia. So thank you very much for participating in this Medscape activity. Please continue to follow the other video presentations. Thank you.